Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying about the tubulointestinal nephritis, and from this either you can get a very short type of note, or you can get a short note. So prepare this topic from that perspective only. Okay, let's start. Tubulointestinal nephritis is basically a group of renal disorders. It is basically a group of renal disorders characterized by inflammatory injury of renal tubules and interstitium. This is the first thing that you need to note it down, with relative sparing of glomeruli and renal vasculatures. See, it is basically a inflammatory injury. Okay, the first thing that occurs in this kind of injury is the inflammation, and it spares the glomeruli and the renal vasculatures, like at least in the earlier stage. Later on, it can involve the vasculatures as well, but in the earlier stage, it excludes this kind of vasculatures. Okay, now, as you all know, the disease can be acute or it can be chronic. That depends on the duration and the pathological features. Like if the duration is of less than 4 weeks, it is acute, and if the duration is more than 4 weeks, then it is chronic, right? So that basically depends on the duration and the pathological factors. Let's see the etiology. For the etiology, drug-induced causes are the most common. Then you have antibiotics. In antibiotics, you have penicillin, cephalosporin, sulfonamides, and rifampicin. And rifampicin is given for the treatment of tuberculosis. That also you should know the TB regimen that we use. Okay. Then we also have NSAIDs, and NSAIDs are for pain relief, right? Diuretics, proton pump inhibitor, and the most common proton pump inhibitor we use is the omeprazole. Okay. Next, infections can also cause this disease, like the bacterial infection, like that caused by the streptococcus or the staphylococcus organisms. In viral, we have the CMV, EBW, Epstein-Barr virus, and the hantavirus. Others are leptospira and mycoplasma. And in leptospira, you need to remember what are the key features that you have are the 3 R's. What? It involves rise and it involves the rain, that is the flood. So if this kind of criteria, like I'll give you a triad also of leptospira. So leptospira has 3 R's. What are the 3 R's? Rat, then rise, rain. Rain means the flood. If this kind of history is given, just think about leptospira. Okay. Other causes are, it can be due to any chronic drug-induced toxicity like NSAIDs, lithium, cyclosporin, and tacrolimus. Metabolic causes are either can be hypercalcemia, hyperuricemia, or hypokalemia. See, hyper are either calcemia or either uricemia, and hypo is only one, that is hypokalemia. Then you have the infections like the chronic pyelonephritis, tuberculosis, and HIV. For the obstruction is mainly due to the stones, so just think about the stones only, or it can be due to the enlarged prostate, the reasons that we have listed for the renal stones as well. Let's talk about the pathogenesis. So for the pathogenesis, you have mainly of 2 types, the acute one, acute tubulointestinal nephritis, or the chronic one. Let's see them. Right. So first we have is the acute one. In the acute one, what happens? Mostly hypersensitivity reactions are involved against drugs or its metabolite bound to tubular basement membrane. Okay. So what happens is the hypersensitivity reaction. It is mainly hypersensitivity reaction, T cell mediated, and what happens is the drug or the metabolite bound to the tubular basement. What is the mechanism? Now listen to me very carefully. First, the drug acts as a haptens. Then it binds to the tubular cells, right? Like if I draw for you, like this is a tubular cell, let's suppose. These are the drugs. So what the drugs will do? It binds to the tubular cell. After that, it triggers the immune response. It triggers the immune response. And finally, they will activate the cytotoxic T cells, eosinophils and macrophages, right? Next you have is the chronic tubulointestinal nephritis. In the chronic one, what you need to remember is there is persistent low-grade injury which will lead to the tubular atrophy and atrophy and intestinal fibrosis. So these are the two things that will occur. What are the two things that will occur? First one, there will be the tubular atrophy, and second one, there will be intestinal fibrosis. Okay, these are the two things that you need to remember in the chronic one. Let me show you the pathology also. In the pathology, the gross image you are able to see. So the gross image, the kidney looks like normal or slightly enlarged. It is in this figure, it is slightly enlarged, but it can be normal also, so it's not a big deal. Okay, and it is small and contracted in the chronic one. In acute one, either it can be normal or enlarged, or in the chronic one, it is small and contracted. In the microscopy, what you are able to see? In the acute one, you are able to see the intestinal edema. You are able to see the eosinophils and the neutrophils that are aggregated, and the glomeruli are normal. Okay. Next, in the CTIN, there is intestinal fibrosis and tubular atrophy. Mononuclear inflammatory cells will be there, and thyroidization of the tubules will be there. That you will see. Let's see the clinical features of them one by one. In the acute one, you have the acute kidney injury. Obviously, if there is acute tubulointestinal nephritis, there will be acute kidney injury. After that, there will be oliguria, there will be a small amount of urine, or there can be polyuria, there can be huge amount of urine that can happen to the person. Hematuria means there will be blood in the urine. There will be mild proteinuria, and there will be nephrotic syndrome that we have read in that chapter of nephrotic syndrome. There will be sterile pyuria. Sterile pyuria means there will be certain infection in the body, and as a result of which the person will also develop fever. Because whenever there is infection in the body, the first response that the body shows is the fever. Okay. Next, about the chronic one, there will be polyuria, huge amount of urine will be there. Nocturia, at night, the person will have the urge to urinate a lot. Okay. It is due to the loss of concentrating ability, because the bladder is not able to concentrate much. So drip by drip, the urine will fall. Okay. There will be hypertension. It is less common in early disease, unlike the glomerulopathies. Progressively worsens, mild proteinuria will be there, and microscopic hematuria will be there. What are the investigations we will do? First thing first, if the problem is in the urine, we have to go for the urine analysis, right? Obviously, if like there is some problem between you and your friend, right? So you will tell your friend that I am having this kind of problem with you. You will not go and tell your brother or sister that I'm having this kind of problem with my friend, right? What will be the issue will not be sorted, right? Similarly, if the problem is in the urine, the first thing that you should do is the urine analysis. So in the urine analysis, you will see the sterile pyuria, you will see the microscopic hematuria, WBC cards, and the eosinophils. Proteinuria, you will also see if it is mild, that is less than 1 g per day, except NSAIDs induced nephrotic syndrome. In the blood test, there will be elevated level of creatinine, because I have already told you that if there will be increased sterile pyuria, so there will be elevated level of creatinine. Eosinophils will be there. Immunological test that you will do is the ANA ANCA, serum Ig4 if any systemic disease is suspect. Okay. Next, you will go for the imaging. After doing the routine investigation, you will go for the imaging. In the imaging, the first thing you have is the ultrasound. In the acute one, it will be normal or enlarged, because we have seen in the pathology also that the gross image was either normal or either enlarged. In the chronic one, the kidneys will be small and shrunken. Definitive will be renal biopsy to do, because you will be able to rule out the disease that the person is suffering from. In the acute one, there will be intestinal edema plus inflammatory infiltrates. In the chronic one, there will be intestinal fibrosis and tubular atrophy. What is the treatment? For the journal principle, identify and remove the offending agents, whatever the agent, whatever the drug is causing, whatever the etiology that we have seen. If you are able to notice that etiology, just remove that etiology immediately. Supportive care will be give person a lot and lot of hydration. Ask the person that please drink a lot and lot of water. There should be correction of the electrolytes. If there is any kind of electrolyte balance that is there, just try to correct the electrolyte balance. Blood pressure control should be there. Okay. Now, the separate treatments that we have for the acute TIN, drug withdrawal, the first thing that should come to your mind. If renal function does not improve, you have to give corticosteroid, right? Prednisone 1 mg per kg per day. Okay. And dialysis if the acute kidney injury is very, very severe. For the chronic one, you have to treat the underlying cause that we have seen. And to manage the CKD, the chronic kidney disease progressive, control the BP and ask the patient to take a low protein diet. What are the complications that can occur? There can be acute kidney injury, there can be chronic kidney injury, progressive to end stage renal disease, and there will be secondary complications of CKD like anemia, like bone disease, like acidosis. So these are basically the things that you need to remember and you need to keep in mind while answering the question of tubulointestinal nephritis. I hope I made myself very, very clear. Thank you so much for watching this lecture. If you are having any sort of doubt, please feel free to ask me. Thank you.